Thank you, Chairman. I'm Jae Keun Oh from Korea. Actually, this session is about the cervical disc arthroplasty, but my topic is the ACDF. My topic is the fusion, sequence, and risk factors for pseudoarthrosis in multi-level ACDF. As you know, there are some complications after ACDF surgery, dysphagia and postoperative hematoma and symptomatic recurrent laryngeal nerve pulse, and one of the complications are pseudoarthrosis. There is a 10% for single-level fusion surgery, but can be as high as from 20 to 40% in multi-level ACDF. There are typically two ways to check the fusion. One is the CT scan and the other one is the flexion extension X-ray. In CT scan, we usually check the presence of a breaching bone. But these descriptions regarding breaching bone are subjective and still lacking, and the type of graft or cage can influence the interpretation of images. So usually, recently we use a flexion extension X-ray. We check the interspinous motion. You can see in X-ray the adjacent level. We check the full flexion and extension. Over 4 millimeter is the adequate flexion extension X-ray. After that, we check the interspinous motion. Under 1 millimeter means the fusion. So you can see this area 17 and 17 good fusion. This 23 good motion, good fusion, but 16 and 12 still pseudoarthrosis. So this technique is published in JBJS 2014. So my topic is the focus to three objects. First object is to compare the fusion rate and mean fusion time across all levels between 2-level and 3-level ACDF. And second object is to compare the fusion rate, mean fusion time at the cranial, middle, and caudal level with each group. And third object is to analyze the risk factors associated with the pseudoarthrosis in multi-level ACDF. Our study is the retrospective study with a minimum 2-year follow-up at one single center. My patients are 119 patients underwent 2-level or 3-level ACDF surgery, and the exclusion criteria are like this. And previously I mentioned that I checked the motion, fusion in the flexion and extension X-ray, interspinous motion under 1 millimeter mean the good fusion state. And this is our result. And 2-level ACDF patients is 93 patients, and 3-level ACDF is 26 cases. In this result, you can see the cumulative fusion rate in 2-level ACDF 73.1% versus the 3-level ACDF 57.7%. And median fusion time showed longer in the 3-level. The 3-level is 18 months, and the 2-level is 13 months. And in 2-level ACDF, the cumulative fusion rate in the cranial level is 91%, and caudal level is 75%. And median fusion time shows the 5.29 months at the cranial level and versus the 13 months at the caudal level. Longer time are necessary in caudal level. In 3-level ACDF, you can see this data, 92% at the cranial level, and then 96% in middle level, and 57% in caudal level. Middle level first, and then cranial, and then caudal. Median fusion time, you can see 8 months at the cranial level, middle level on the 2.7 months, and the caudal level 18 months. This is the hazard ratio in 2-level ACDF. In caudal level has 2.86 higher risk compared with the cranial level. In 3-level ACDF, you can see the middle level and caudal level 9 higher risk in the pseudoarthrosis in the caudal level. This is an example case. 41 male patient. We did a 3-level ACDF. This is after 3 months, 6 months, and 12 months, and 2 years after surgery. You can see in 3 months, the 5, 6, just under 1 millimeter. So this is fused, but still remain motion 4, 5, and 6, 7. After 24 months, after 2 years, the 4, 5 under 1 millimeter, it means the fusion. 5, 6 is 0.1 fusion, but still pseudoarthrosis in 6, 7 level. In multivariate regression analysis, we can see the risk factor in ACDF surgery. The peak cage, using peak cage is a higher risk in pseudoarthrosis. And multi-level surgeries see the pseudoarthrosis risk higher. This is a peak cage using cases in 70 years male patient in 3-level ACDF. You can see even the 2 years after surgery, the 4, 5 is still 2.9 millimeter motion, 5, 6 is 0.7, and 6, 7 is pseudoarthrosis. This study is a retrospective study, so there is some limitation, but I think our study had a detailed insight into fusion sequence and timeline, and we can give the implication for caudal fusion improvement. But we need a prospective and multi-center studies. These are our conclusions. In 2-level ACDF results in higher fusion rate and shorter fusion times compared to 3-level ACDF. In fusion sequence from the middle and then cranial and then caudal fusion is happened. And peak cage use and multi-level ACDF were identified as significant risk factors for pseudoarthrosis, particularly at the caudal level. And importance of careful surgical planning and material selection to optimize outcomes, especially in multi-level ACDF procedure. Thank you for your attention.